Hello, all. A warm welcome to everyone. I'll be running you through some housekeeping points for a smooth interaction today. Everyone is muted by default. You can choose to have your camera on or off. Our panel will be more than happy to see you all. You're allowed to post questions in the chat box. The panel will try to answer all of them. However, if we run out of time, the unanswered questions would be responded through LinkedIn later on. This whole session is being recorded, and you can drop in the chat box if you encounter any technical issues, and we'll try our best to resolve them.
Next slide, please. Good evening, everyone. My name is Aarti Raghavan. I'm the Program Director for the Graduate Studies in Patient Safety Leadership at the University of Illinois in Chicago. It is my pleasure to welcome you all today for this panel discussion on the value of a voice in patient safety, and for us to understand how we can take patient safety leadership and put it to action. On March 25th of 2022, in a Tennessee courtroom, a former nurse was convicted of 2 felonies and faced 3 to 6 years in prison. This case is our discussion for today. Next slide, please. Before we even begin this discussion, the panelists would like to just share that this discussion is really more about the anatomy of a safety event. It speaks more to systems issues than to individual issues, more to latent conditions and latent errors that occur when there are systemic weaknesses, as opposed to active errors that may occur on the sharp end of an instrument. Next slide, please. I'm honored today to present my colleagues who are my partners in the patient safety leadership programs at UIC. These individuals are not just faculty within the program, but are also experienced and nationally recognized full-time leaders in patient safety across the country. With that, I present Jonathan Cohen, Carrie Gailey, Amanda Kensler, Jerry Maloney, George Vukotic, and CJ Wolf. And last, but of course not the least, Sherry Hill-Leahy. Sherry is one of our assistant program directors, in addition to leading our capstone projects within the master's program. She also serves as the associate vice president of the 3rd largest healthcare system within the state of Illinois. With that, I present Sherry. Next slide, please.
Thank you, Aarti. So I'm going to walk you through this case so that we can all kind of get a feel and in our hearts what it was like to go through this medication error. So essentially, there's a couple of high points. This case is about a nurse, former nurse RaDonda Vaught. She began working in the intensive care unit at Vanderbilt University, the largest hospital in Nashville and one of the most respected hospitals in the nation, in October of 2015. And the event that we're going to talk about today was occurring in December of 2017, when a patient by the name of Charlene Murphy, age 75, died at the hospital after being injected with the wrong drug. Versed was ordered for this patient for anxiety, but becuronium was given instead, which is a paralytic, and the patient ended up passing away. In March of 22, and I'm sure many of you have already heard about this because it was very big in social media and on the news, that this RaDonda was convicted on 2 counts in the death of Charlene, criminally negligent homicide and abuse of an impaired adult. This was really quite a significant event, and statements from the American Nurses Association and the American Association of Critical Care Nurses basically said that this sets a dangerous precedent. So let's take a look at this a little bit more in depth in terms of a timeline. And when we look at patient safety events, we always want to walk through the timeline and try to understand what happened and where the errors could be prevented. So on 12/24/2017, Charlene Murphy, as I mentioned, is a 75-year-old patient. She had a history of cancer, and she was admitted to Vanderbilt Hospital with symptoms of a potential brain bleed. On 12/26, just 2 days later, her condition was already improving and she was almost ready for discharge. The physician ordered a PET scan, a procedure to determine really the cause of the bleed. And the patient requested something for anxiety. She had a history of claustrophobia. So her physician ordered 1 milligram of Versed, which is an anti-anxiety medication. And the nurse Vaught was assigned that day as a float nurse. And so she was asked by another nurse to help out. She was just a helper, actually, trying to assist in moving things along. And she was asked to administer the Versed to the patient down in radiology right before the scan. So the sequence of events at that time, the patient was transported to radiology. The nurse was instructed to go to radiology to give the Versed. So she attempted to get this medication from an automatic dispensing cabinet. You might have heard it called Pyxis. That's one example of one of those. And she could not find the medication and used a system override to obtain the medication. This is a safeguard that's put in place. You're not supposed to override the medication cabinet, but it was condoned by the hospital leadership because there were issues with the system, and she was doing something that she had been told was okay to do. She was also talking to an orientee at that time. She had a trainee with her, and as she was talking, she typed into the dispensing cabinet VE and chose the first medication on the list. She accidentally obtained a vial of vecuronium bromide, a paralytic used during surgery, while a patient is intubated instead of the Versed for anxiety. So Bob removed this medication vial without checking the drug name or the warning, and you can see how it looked and how it is labeled. And so she missed that, and she really just looked at the back of the vial to really see what the instructions were to reconstitute this medication. So she took that, she put everything in a plastic baggie, labeled it correctly, and proceeded down to the PET scan area. She had never actually been in radiology before and didn't even know actually how to get there. So this was a very unusual environment for her, and she was not familiar with where she was going. When she got there, however, she checked the patient. She talked with her, asked her identity, which is proper and what she should be doing. She told her that she's the nurse who was here to give her something to relax. Now, there was one other safeguard in place in many areas in this hospital, and that's known as barcode scanning. So that you have another opportunity to pick up a wrong drug or wrong patient. And in this case, barcode scan was not available in this procedural area. So she wasn't able to do that. So she reconstituted the medication and administered what she believed was 1 milligram of Versed, but it was actually, as we know, the vecuronium to the patient at the bedside in radiology. She put all of the leftover medication in the baggie. She left radiology and returned to her floor and gave that to the primary nurse. What followed then was really a very distressing situation. The patient was unresponsive. About 30 minutes later, the patient was resuscitated but never did regain consciousness. And while the code was being called up on the unit, the nurse realized that she had given the patient the wrong medication. And she spoke up immediately and informed the physicians and her supervisor about the errors that she had made. She even said that she was distracted while obtaining and administering the medication. And then the staff did confirm that the medication in the baggie was what was administered and it was not Versed. Lots of things happened at this time. It was very, chaotic, I'm sure, but she was told by her nurse manager not to chart this medication. There was some confusion about who would actually do that. So she did not chart the medication. There was a disclosure made to the patient's family at some point within hours of the error, we're told, but the disclosure was not documented. So we're not sure. And then on December 27th, the patient actually expired about 8 hours after the medication was given. So lots of things happened, of course, when there's a chaotic situation, as I mentioned, and there were things that hospital leadership didn't do that maybe could have been done. And some of those things started right away. For example, the coroner, this was a coroner's case, the coroner was not notified of the medication error, and the hospital reported that the patient died of natural causes. So there were situations with regulatory requirements that weren't followed. So a sentinel event report was not filed with the state as required. And unfortunately, 7 days after the event, the nurse, Redonda Vaught, was terminated, and the Tennessee Board of Nursing was notified. However, at that time, the Tennessee Board did not take any action. In 2018, the family reached an out-of-court settlement with the hospital. But also during that time in 2018, there was an anonymous tipster, probably someone from within the hospital, that alerted state and federal health officials of this unreported medication error and that it was responsible for this patient's death. So this started a chain of events, including a full survey by the Centers for Medicare and Medicaid Services. They conducted a complete inspection of the hospital and issued a very lengthy statement of deficiencies that concerned this patient's death, but picked up many things that were wrong with the hospitals at that time. In 2019, RaDonda Bhatt was arrested and charged with reckless homicide, impaired adult abuse. And 2 years after that, her nursing license was revoked. And as we know, in 2022, a jury found her guilty of criminal negligent homicide and impaired adult abuse. At that time, March of this year, the American Nurses Association and the Tennessee Nurses Association issued a joint statement. And I think this is really kind of the foundation of how we feel things can be in patient safety science. And here they're saying healthcare delivery is highly complex. It is inevitable that mistakes will happen and systems will fail. It is completely unrealistic to think otherwise. The criminalization of medical errors is unnerving, and this verdict sets in motion a dangerous precedent. There are more effective and just mechanisms to examine errors, establish system improvements, and take corrective action. The non-intentional acts of individual nurses like RaDonda Bhatt should not be criminalized to ensure patient safety. And this really instigated a firestorm of support for the nurse. And actually the family came out and during the trial said that the patient would have forgiven the nurse if she had lived, and the family forgave RaDonda for this error, knowing that it wasn't her fault alone. And social media backlash was enormous, lots of support for her. And the sentencing was in May of this year, and hundreds of supporters and nurses from across the nation descended on Nashville to rally for the nurse during the time that the sentence was occurring. And thankfully, RaDonda Bhatt was sentenced to serve 3 years of probation, and she received a diverted sentence, meaning that if she meets the terms of her probation, these charges can be wiped from her record. So there was a great deal of relief around the way that this was handled and the fact that she didn't have to go to prison. So today we're going to talk about a couple of things, points from the case that I just went over, and they're failure points that I mentioned that really could use a little bit more in-depth discussion. So I mentioned that she did go to an unfamiliar area. She was a float nurse and she floated down to the radiology area where she had never been. She used override functions to get a medication, which was condoned actually by the hospital leaders, as I mentioned, because there were problems with the new medical record, electronic medical record, that caused delays in the system that had been put in place to prevent errors. She also was not able to use barcode technology, as that was not available. And while she was preparing this medication, I mentioned she was orienting a new staff member. She was distracted and really didn't confirm the label and look at the vial before she administered this to the patient. However, she did speak up and she did inform people. She said that this was the right thing to do, and she did not delay in doing that. However, blame was placed on her as an individual. She was terminated. And we're going to talk a little bit about a second victim program, but no support was offered to her. And leadership finally did not follow the regulatory procedures for reporting and disclosure. So many failure points in this case, but these are ones that are particularly significant that we want to talk about. So with that, I'm going to send it back to Artie to talk about our first failure point.
Thanks so much, Sherry. I've heard this story so many times, and every time I listen to it, it hits way too close to home for comfort. I'm not a nurse, I'm a physician, but I could see myself experiencing the same kind of fatigue that RaDonda had, the level of distraction that she experienced. And we have in our panel today Amanda Kensler, who is a senior risk manager in what I call her day job, but also someone who has a lot of expertise in human factors. And Amanda, I was wondering if you could comment on sort of what you think went wrong in this situation from a human factors perspective, and maybe what could have been done to overcome it or to prevent it? Because we all know fatigue is not preventable. Distraction, is it really preventable?
Well, thank you for letting me talk for a few minutes today. Yes, I don't know. And that's a little bit of what I was going to talk about tonight was, many of these things are really non-preventable because it's everyday work. And that's, I think, what resonates with all of us is that you can feel it because we all experience this, walking down the hall, talking to an orientee, trying to get other things done. And I think that's the struggle that all of us can feel, this struggle that she's just trying to multitask, right? And so looking at the human factors portion of this case, it's interesting to us because we can kind of peel away the sections a little bit of the onion, right? And it's easier to peel these away, but actually, that doesn't take away the accountability of others and others' accountability. And sure, she does have a certain amount of responsibility and accountability. And that's what I kind of wanted to talk about tonight too, is, work as imagined versus work as done. And work as imagined basically is kind of, all of us in our society, we create policies and we create guidelines based on our laws and regulating bodies and all of those overarching organizations that oversee healthcare, right? And so we have all of these, and we create all of our policies based on that and based on our laws and the BO, the Board of Nursing and the medical boards, right? So we have this, that's kind of our work as imagined, right? And RaDonda Vaught, as a seasoned nurse, she knew how to give medication and she knew what was acceptable in her environment. And I believe, Sherry mentioned in the story that she was orientating at the same time and she pulled from the Pyxis, and the override function was basically what everyone was doing, right? So the override was kind of normal behavior for that institution. That was kind of their culture at the moment. And all of us have these new softwares and new technology and new everything all the time. So we're finding ourselves on the edge of almost unacceptable behavior, but not quite. I think we kind of live in that at-risk behavior oftentimes because of all the social technical skills and the culture that we live in. And it really isn't uncommon for all of us to have these things happen. And that's kind of what we would call work as done. It's different than work as imagined versus work as done, because we have these imaginary thinking that we'll follow the policies, this is what it says, but we kind of get close to the edge of all of our, because of time constraints and workload and all of those things. And that's kind of what I get into discretionary space, because we, as humans, we kind of have this discretionary space where we have these laws that are created, our regulations and our policies that we know we aren't supposed to cross over, but we often live at the very edge of those. And why do we live? Because we have competing factors such as time constraints, workload, and we create this series of events based on to save ourselves energy and to save ourselves on time. And as a float nurse that day, she had all these competing responsibilities. And like I said, the orientee heading to the ER after she had this task, and she's just pulling the medication, going to where she's going to go. She had to actually mix this medication, although that was not a medication that was supposed to be mixed. But how many of us as nurses pick up a medication that has always been blue, but the pharmacy bought another medication and now it's pink instead of blue? I mean, those things happen to us all the time. And so nothing to her seemed that out of place. But often, I'll tell you, one of the things I was going to talk about with the multitasking, I heard a comment the other day from a book written by Joanne Harry, and the name of her book is Stolen Focus. And every time that a task that you add to another task decreases your effectiveness of that task by 12 to 24%. And so every task that you add, you do this multitasking, you're more likely to make a mistake multitasking than you are with just doing a single task at a time. But as all of us know in healthcare, we do multitasking continually. It's like a chronic thing. And I don't know that we ought to actually look at that and see if that's the way we need to continue our work. And often, because we multitask, we've kind of drifted into the fact that that's commonplace for us. So we've drifted so close to the edge that we're likely to pass over to more reckless behavior than we would if, and we've kind of been sitting at this at-risk behavior. So that's kind of the comments that I have to state about that at this current time, and appreciate you letting me talk. And if anybody has any questions, I can't see the chat currently.
Thanks so much, Amanda. I think it really makes me, as a provider, really rethink how many tasks I take on, and the idea that it's 12 to 24% for each task is a little scary, because there are times where I think the numbers would add up to more than 100%. And so it makes me realize that sometimes slowing down is critical in that moment. But that is something that I think many of us don't recognize even in the moment as we go through our day, which is things have to get done, like you said, and you try to layer things one above the other. Which sort of brings me to my next question, which is related to training. And I wonder how much of Redonda's situation could have been overcome had she been trained in the environment in which she ended up practicing, at least for this particular situation. And we have another panelist with us today, Carrie Gailey. Carrie is an organizational expert. She's a pediatric nurse practitioner and a process improvement specialist, and serves as a consultant in many organizations with their quality and safety and process improvement methodology. And Carrie, I'm curious what your thoughts are on training, and how much of that you think could actually overcome some of the stuff that Amanda was talking about in terms of human factors issues that come up. Do you think that training alone is enough?
I think it's a great start, and I appreciate the opportunity to, hopefully my voice will hold out, have a conversation today in regard to the value of training. I do think that I can't say that it would have totally changed the outcome, but I think having a good foundation is like building something on cement versus building something on Twinkies. And if you don't have training, you're just, the opportunities for failures are just exponentially increased. In regard to this specific case, I thought long and hard about what we do and being a nurse and having to float and the stress it adds to all of the concerns that Amanda brought up and the challenges that exist. And I remember very distinctly floating as a nurse. I've been in nursing for 38 years, but back when even 2 years, even though people are like, well, she's been a nurse for a long time, that's really not a long time. And especially going to a different unit, I have no idea if the workflows are the same in those different areas. Was there any cross training for those individuals? What was the orientation when she got to that unit? What was her comfort in addition to having an orientee? It just added another huge layer of complexity that could have mitigated some of the circumstances. And then I really want to look at training from a really broad perspective, because I truly believe that basic training in quality and safety is a system need for every area, for all people who provide care in a healthcare institution. I think what Redonda did in speaking up was to be praised immensely. Though she had a voice, it didn't sound like it was culturally or systemically heard. And I think that if we could make it a requirement that people spoke the same language, they understood the value of quality and safety, that we would really escalate the care that we could provide, and then together as a team decrease some of the challenges that are out there. When I was thinking about it before, I tried to equate it. If you think about a auto manufacturer line and jobs, they're specific. People are very comfortable in the roles that they have. And somebody works on an engine, oh, but we're short-staffed, we're going to throw them down into the tire and adding tires onto your automobile. How comfortable would you be having someone without any orientation, maybe without standardized workflows, putting your tires on who never did that before?
Thanks, Gary. I think you've made some great points, and because in the world of quality and safety, we have drawn so much from the aviation industry. This makes me draw parallels again, and if we expect a nurse to be able to cross-cover different units. There's some comments in the chat box about whether orientation is standardized when you cross-cover other units. And I think if anything has sort of thrown a magnifier over this whole picture, it is the pandemic. So many people were asked to cross-cover in so many different places. And yes, it was a crisis beyond what anyone could manage at a unit level. But that being said, we would never ever ask a fixed wing pilot to fly a chopper. It would just never happen, because that's the way licensing is set up, and that's the way the aviation industry works. And it's it's been a long time since the To Err is Human report came out, when patient safety actually made it on the agenda nationally. But even so many years later, I think there's still a lack of recognition across the country in terms of how much training actually matters, and how much, particularly some foundational elements. There may be variations in clinical care, but there are some foundational elements, like you mentioned, around quality and safety that just don't seem to make it to the surface as far as cross-training is concerned. And I think that speaks to the importance of having pieces in place like technology that we're going to talk about in a second. But I also just want to share with the team that Amanda and Carrie, who you just heard from, are faculty within the PSL programs. They actually teach courses on error science, risk, and disclosure. That course is taught by Amanda, and that course takes a really deep dive into human factors, exploring factors that come into play at different levels across the hospital system, but also speaks to the importance of error reporting, speaking up, and communication. Carrie's focus is primarily on process improvement and implementation science, and we actually have a newly constructed course on that that is available for both folks who are taking the graduate certificate program as well as the master's program in quality and safety. Thank you so much, Carrie. This brings us to the piece on technology. I can't think of another place that's busier, where the need and reliance for technology is higher than in an emergency room. And we have with us today an emergency room physician, Gerald Maloney, who is the associate director of one of the busiest EDs in the country. He's also the physician champion for medication safety for that ED. And I'm really curious, Jerry, what your perspective is on what went down in this case, and also what the role of technology was. And Jerry also teaches our course on simulation technology and applied leadership. And so I'm really curious, Jerry, to hear what your thoughts are on this.
Well, I guess I'll start off by saying, when we started doing things like CPOE and electronic prescribing, there was a general assumption that was going to take care of most of the errors with medication safety, because before that, most errors had been transcriptions. Somebody literally read handwriting incorrectly, or somebody wrote down the wrong dose. And the thought was, hey, electronics prescribe will take care of all that. It is not. One of the issues here that came up that was discussed earlier was the idea of overrides, and also how you could pull the wrong medication so easily out of the automated dispensing cabinet. One change that has actually come out of this was that previously you could pull a medication by just entering in the first 2 letters of the medication. It was also unclear. We tend to think a lot of times in terms of brand names of medications like Versed, but it was actually listed as midazolam, the generic name, in the automated dispensing cabinet. When Ms. Vaught put in VE, something came up and she, again, distracted, quickly didn't carefully read what had come up. What had come up, of course, was vecuronium, not Versed, and Versed wouldn't have come up the way the medications were logged into the automated dispensing cabinet. A change that they decided to make was to actually fix it so that now 4 to 5 letters have to be entered in the drug for anything to come up to be able to open the cabinet. So that has actually drastically limited these really quick name recognition mistakes that can come. That hasn't been adopted universally, but I expect when the Institute for Safe Medication Practices, ISMP, comes up with recommendations for medication safety for the coming year, that's probably going to be one of them. The lack of barcode scanning has been mentioned as well. That's been a fallback that all that has its issues as well. People have found workarounds for barcode scanning. And I see those pop up in safety reports at our organization all the time. That still reduces the likelihood you're gonna make the mistake. For example, you scan the medication, pulls up vecuronium, you scan the patient's wristband, it doesn't show an order for vecuronium anywhere. And that would be literally an at the bedside last stop default. The absence of barcode scanning was a huge contributor in this case to the patient being permitted to be given the wrong medication. When we look at the idea of using electronic prescribing in general, it's the number of errors have actually increased. I'm just old enough that I remember having to handwrite everything in residency, and the transitional electronic medical records happened around the time I got out of residency, before I started getting heavily involved in patient safety. By the time I started doing a lot of medication safety stuff about 12 years ago, everything was being electronically prescribed, and talking to people who have been doing the medication safety stuff before then, they said the number of error reports had gone up drastically. Partly that was because it's easier to track, but partly because there's new errors that come in. A big problem winds up being overriding, not just at the automated dispensing cabinet, but overriding alerts that come up. Alert fatigue is a big problem with technology. And anybody who's used electronic medical record is probably aware of it, although they've talked about a similar thing, alarm fatigue in the ICU. There's alert fatigue with, saying popping up danger, there's a drug interaction, the patient's on a vitamin that will decrease absorption of this medication, which most of us wouldn't get too excited about, versus danger. There's a critical drug-drug interaction that could jeopardize the patient's health. You see so many alerts pop up, people just get used to clicking past them. And unless something becomes a harder stop than even clicking on the alert, you can still have critical medication errors despite having a robust alert system. Particularly with this case, the easy ability to override medications, the ability to pull medications with minimal information being entered, and the lack of barcode scanning were all major factors in the technological end that contributed to this fatal error.
Thanks, Jerry. I had a quick question about a concept that I've read about called the normalization of deviance. can you speak a little bit to that concept where, we know something is not the right way or not the best way to do something, but we still end up doing it? And my understanding is that a lot of times that's because that's actually the easier way to do something. And I'm curious what your thoughts are on that in this particular case where the nurse was actually instructed for certain pieces of this for her to override certain elements that were in place because the system was down. And I'm curious what your thoughts are on that.
Normalization deviance happens across multiple areas, particularly with HIT in general and medication safety. When processes are put in place that people see as slowing down patient care or adding steps, people start trying to find workarounds. And when those workarounds improve efficiency, then they wind up being accepted, even if they're not the correct thing to do. Verbal orders have become one way. I'll give an example, just my own place. Verbal orders is supposed to be used only in life and death situations. You're in the middle of a resuscitation, then verbal orders are okay. Every other time you're supposed to be giving or entering the order electronically. There are several providers who, because the verbal orders are faster, they give them anyway. The nurses usually don't fight it. And then we've had multiple instances where, hey, we've had medication discrepancies now because something is verbal ordered, but never entered in. We have medications pulled from the PICSs with no order attached, but that continues to go on. In this case, the overriding was part of this normalization of deviance. I talked about barcoding being able to be overridden, and we had an issue when we first started doing barcode med administration about 5 years ago, where because there were errors sometimes the barcode readers, and because it slowed the nurses down at the bedside, particularly upstairs in the inpatient ward, where sometimes they're passing 7 or 8 medications to a patient at once, and they're trying to multiple patients in sequence, they would find a workaround that allowed them to say the barcode scanner wasn't working, even if it was, just to administer the medications to the patient. And that became accepted because it improved the efficiency. So the normalization deviance is usually in response to what's perceived as a system that's not working. And it's something that is a response to that because the frontline workers perceive the solution as being acceptable, even though it's technically violating policy.
Thank you so much, Jerry. I think that was really helpful because the technology piece of it seems to be the quote unquote obvious fix in this case, but as we're learning, it clearly isn't. As I listen to the analysis of the case, I really worry and wonder about what happened to the nurse. Was she given any support? And also, not just her, but what about all the others in that department or across the hospital as this case has sort of evolved over the last 3 years? I'm curious what sort of support was provided, because we already know that burnout rates have been extremely high in the last few years. And it makes me wonder how many people are actually evaluating their careers and thinking about whether this is something that is worth pursuing. We have with us today Jonathan Cohen. He is the patient safety officer for the Department of Anesthesia at Moffitt Cancer Center, and is also one of our faculty member with the PSL programs. And Jonathan, I was curious what your thoughts are on the Care for the Caregiver programs, the presence or absence of it in this case, and whether you think it would have been helpful or is helpful.
Sure. Thanks, Artie, for asking the question. Well, one of the things is, in order to provide care for the caregiver, the fundamental thing to all of that, which I think sometimes is missed or looked over or minimized, is the establishment of a just culture. That's where everything needs to start from, because without a just culture, nothing else you do really seems to matter. Now, we heard earlier a quote from the American Hospital Association, but in another quote, they said, we cannot punish our way to safer medical practices. What a just culture is, and there's sometimes a lot of confusion. It's not a blameless culture. It's not a culture of no accountability. In fact, it's quite opposite. It is a culture of increased accountability, but it's the right appropriation of the accountability. For instance, we heard it in this case, a lack of barcode scanning, workarounds being tolerated, ease of getting vecuronium to a patient. These are problems that occur within the system. So what a just culture does is it considers what RaDonda Vaught did and what she may have done, but it also considers the system that she worked in, and it makes sure that the accountability lies with the right spot. It's not scapegoating. Blame is very rarely the problem. Blame is assigning, responsibility for things. Scapegoating is the real problem, which is falsely assigning responsibility to one individual for the faults of an entire system. Now, regardless of which just culture algorithm is used, the breaking point, whether you use Dave Marks or you use James Reason or some of the other ones that are available, the breaking point is if an employee consciously disregards a known risk. And what we need to remember is that very, very few errors actually occur as a result of purposeful intent of a healthcare worker or just a complete wanton disregard of the rules. These are people who intend to do the right thing, the best thing for the patients and take care of them. So did they know that there was a risk there, or did they mistakenly believe that it was justified? Now, in this case, she was fired. And some people said that, it's not a just culture, she was fired. But I want to also point out that we don't know all of the details, not just of this case, but of the history. So if someone makes a mistake, they give the wrong medication, that's one thing. If they have a habit of giving the wrong medication, there's a pattern of things that occur in the past. Separating, an employee from a position within a hospital or healthcare environment is the appropriate thing to do and does follow along with the just culture. And like I said, there are some details with this case that we'll just never know because it's just not going to come out. Now, we can talk about just culture for the whole hour, but I just want to point out a couple of things. The first thing is that the basis of a just culture and what it depends on greatly is the quality of the event review. So Fitz and Jones looked in 1947 at pilot error. In fact, in their paper that they published, they put pilot error in quotes because they realized that these are, the pilots really weren't making errors. They were doing what seemed to make sense at the time. It's the design of the system, which Amanda alluded to earlier, is what is causing certain errors. So blaming things on human error is actually the start of the investigation, the event review. It's not the end. So when people make mistakes, we need to say, why did they make mistakes? Why did it make sense to them at the time? What else is going on that kind of puts this together? Without fully investigating events, you're not going to have a just culture because you're going to stop at human error. It's easy to blame RaDonda Vaught for what happened here and do that, but that's not going to prevent someone else from making the same mistake. The next thing that we talk about, and this comes from Virginia Mason, it's called a clinician autopause, which is kind of allowing people time for healing, reflection, and support when they're involved in a medical error. And this is kind of what Virginia Mason does. We've expanded that at our institution to say any serious unexpected outcome. So when something happens that's not completely expected, something horrible, you allow people time away from direct patient care to kind of settle and deal with it. You don't put them right back in to caring patients. It may not be known whether a medical error or an adverse event happened or this was something completely separate. That's something that occurs after an investigation. So you can't wait until an investigation is done to give people the time to kind of heal. So sometimes one of the big sticking points, at least it was at our institution, like, wait a second, you want to send people home in the middle of the day? How is that going to allow us to care for our patients? The easy way to counter this is how often do you think something like this is going to happen? If it's going to happen so often, we're going to be sending tons of people home and we're not going to be able to provide care for patients, then really we need to be looking at our processes and seeing what else is going on. And then finally, the last thing that I want to talk about as far as providing care for the caregiver is peer support. And it's been shown in several studies that the resource that most people want when they're involved in either a medical error or a harm event or a serious unexpected event is a respected peer to discuss the details of what happened to. And the goal is to help the affected team members process their feelings so that they can return to work safely. This isn't employee assistance program. It's not therapy or counseling. And sometimes those are needed and it needs to escalate. But what is most commonly needed is people just need someone to listen to them and let them tell their story and reflect back. And it needs to be a peer. That's something that we found. If you're in the operating room, you want to talk to someone who works in the operating room. If you're working on the floor, you want to talk to someone who works on the floor. If you're a nurse or pharmacist, you typically want to talk to another nurse or pharmacist, someone who can relate to kind of what you've been through and maybe can share that experience with you. The key though is that when this happens, and it can be done very easily, it can be done wrong. So there are training programs for this, and I strongly, advocate for them because it's kind of listening with reflection, but the tendency is to kind of ask questions of people. What happened? Tell me, and it's not there, you're not there to investigate. You're there to kind of listen, let the person come to you in their time and give their account of what happened and kind of just allow them to kind of reflect back on their feelings and things like that. We had a peer support program at Moffitt now for a year, a formal peer support program. We have a hotline that people can call 24 hours a day. I don't know if any of you can guess how many calls we've had at our hotline as of today. Anyone? Artie? Take a guess.
Please tell me that it was more than 0.
It actually is 0. And while that sounds atrocious and horrible, it actually, our program works. And the reason why is because people didn't want to call a hotline. They wanted to talk to someone that they knew. They wanted to select the peer that they would kind of share these things with. So we kind of changed our approach early on when we saw that we weren't getting the response. We started training people in each unit so that people would have someone, and we identify them with stickers on their badge that they can identify, and select from the people that they work with to kind of share this to. And also by training peer supporters, it allows the peer supporters to kind of engage and proactively go after, I noticed that you've been down lately, you've had a rough day, something unexpected happened, do you want to talk about it? Because a lot of times people are afraid to approach other people who are, sad or upset. They're not sure what to say or what to do. But by training these peer supporters, we created kind of a proactive program rather than waiting for someone to call. We were going after them. So the number of encounters that we've had with our staff is actually quite a bit, despite the fact that after a year, we've had 0 people calling in. It's become from a reactive program to more of a proactive program. So those are kind of just the things I want to talk about with the second victim support.
It's really heartening to hear, Jonathan, about the success of the Care for the Caregiver program. I think, it takes a very high degree of reflection at the leadership level in any organization to really prioritize the people that are doing the work. The outcomes are only as good as the functionality of the people who are doing the work. And to me, it's very heartening to hear stories where the hospital leadership recognizes it and invests in it. And I think the same is true for the point you made earlier about the just culture and the balance of blame with accountability. And that sort of reminds me of George Vukotic and the work that he does around leadership. And I'm an alum of the Patient Safety Leadership Program myself, as are you, Jonathan. And I remember his course and his approach to teaching leadership. And for the first time, I think I realized when I took the course that even at the mid-level in an organization, or even at the entry level in an organization, leadership exists. And it carries more power than people recognize. And I'm curious what George's thoughts are on the role of leadership in this case, and what the level of accountability is for leaders across the healthcare institutions, including this one where this incident happened. And George, could you tell us a little bit about the different models of leadership that are out there, and what can we apply at the mid-level or at the entry level of leadership in an organization?
Sure, Artie. I think you touched on, and some of the previous speakers have touched on a number of important points. But first of all, where is leadership? What is the role of leadership? I think quite often we have more questions than we may have answers. But if you look at this particular scenario, what is the role of leadership here? We've heard that some people at different levels were told that they could do things a certain way, or there were some workarounds that were permissible. But in the end, do leaders have any liability? You have a person here, and in this case, unfortunately, may ruin her career. But what about the leadership that was involved? Now, we don't have all the details, but were those leaders held accountable as well? So I think anytime you look at a case, and we work with a number of cases in our program to try and do that analysis to see where the issues could be or how they could have been addressed. You know, you talk about leadership, and there's a number of different models. So there's the positive models where people are saying, I'm a servant leader, or I'm an authentic leader, I'm a transformational leader, and that's all well and done. And then there's people that get referred to as, you know, bureaucratic leaders and, you know, authentic leaders that aren't nearly as credible. And I'll go so far as to say there's even some people that are classified as seagull leaders. Now, that's not in our textbooks, but have you ever worked in an environment where you had somebody come in as a leader and they squawked a lot, complained, basically shit all over the place, left and got a promotion, and left it for everybody else to clean up and take after? So there's a lot of different models of leadership and a lot of characteristics of leadership. But what's key is that for individuals, and going through our program, what I try to help the individuals do is learn about certain tools and skill sets that they can have and can apply. And some of the most important are communication. You know, most people think about communication here is our ability to speak to somebody else, but we also need to have the listening skills in other areas. So if you look at communication, what's involved with that? Another area of importance is decision-making. In an environment like we have here in this case, who makes what decisions? You know, how are they written? What are the expectations? If there's an escalation process, what happens? I think here in this case, you clearly had an individual that didn't have any criminal or negative intent. They wanted to do something very positive, but they may not have had a model to follow as far as decision-making process. And then what was already touched on was the culture of the organization. You know, is it an organization that encourages people to speak up when they see issues or not? And then quite often there's changes that happen, whether it's changes in the technology that we've talked about or processes. And I use a model in our program called the PESTEL model. And if you think about it, you know, what it stands for, the first P is for political. Can you think about how many political changes we've had lately with COVID and how that impacts the way we do business? You know, so P for political. E, economic. What about the social? You know, insurance cases, liabilities, things that come into play. How's our society change? If you look at the S, the social aspects. So there's those aspects as well. How do people treat each other? Ties in with culture. The T we talked about for technology. How have technological changes happened and how have they impacted how we do business? And in some cases it is a business or just how we practice. And then E, environmental. You know, what has changed in our environment that impacts us? And then finally, the L stands for legal and how these legal changes have impacted things, lawsuits, different things as well. So again, when it comes back to it, and when you talk about, you know, the role of leadership, quite often I ask is, you know, where is leadership? What decisions did they make? How did they communicate? And in the end, do they have any liability to themselves as well?
Love it, George. I love the PESTEL model because I think it speaks to so many factors in the world of quality and safety that we don't necessarily verbally acknowledge. It's there in the background, things like environment, things like legal. It's sort of the white elephant in the room, but we don't talk about it and we assume that it is just part of our day-to-day functioning. But it also makes me think of a course that CJ teaches in the program, which is about regulation. And you know, what role does regulation really play? I mean, we've seen in this particular case that there was so many different layers, whether it was the nursing board, whether it was you know, the court of law. There's so many different sort of quote unquote regulatory bodies, CMS, you know, they're all out there. And how, what is their role? What's their philosophy and their perspective on patient safety, and how does that impact how we practice? Because you know, that saying that's been going around, if you don't govern yourself, someone else will. And how much of this is related to that, and how do these two pieces intersect? There is, if we take just culture to a grander scheme, beyond the constraints of a healthcare organization and take it to society as a whole, we as healthcare providers and as healthcare organizations have a certain level of accountability to society as well. But we also have to have an ability to self-govern. And where do those two pieces intersect? And I'm curious what CJ's opinion is on it, and what his perspective is from the other side. CJ?
Yeah, thanks, Artie. You know, it's a really interesting discussion to have. And there's so many conflicting and competing perspectives in healthcare, right? A lot of what my colleagues have talked about are that immediate issue and how to correct those. But our graduates are going to who? They're going to the C-suite. They're going to leaders, as George just said, and they're trying to convince them to invest in patient safety, in programs and those sorts of things. What are those individuals faced with? And so in the course that I teach, we talk about economics in healthcare. So kind of this bigger stew, right? None of these patient safety issues happen in a vacuum. It's in the milieu of all these other pressures that health systems are faced with, shrinking margins, right? Reimbursement. Those are some of the things that we talk about. And I'll just give one really quick example because I see so many good questions coming in. I know we want to get to those. One example came out a few years ago from the Department of Justice. It's referred to as the Yates Memo. Sally Quillian Yates, many people may have heard of her. She was the Deputy Attorney General. And she issued this memo in regards to corporate wrongdoing and holding individuals accountable. It makes sense in that arena, right? But I sometimes wonder, does that attitude of holding individuals accountable bleed over into other areas in which it was not intended? And has been well put by my colleagues, it's not just individual blame, it's the systems, right? But I think sometimes it's easy for us to take those messages from other areas of healthcare and other regulators and other enforcement and try to use that as, I don't know, maybe as an excuse to not dig deep into what the real problem is. So there's lots of interesting things to talk about, kind of this greater environment in which all of healthcare takes place. And that's one of the things that we do in the economics, policy, and environment course.
Thanks so much, CJ. And just a little more about CJ. He is a physician and a healthcare consultant with over 20 years of experience. He works as a consultant for both academic and non-academic healthcare organizations from a regulation perspective. Thank you so much, CJ. I think we have a few minutes left for questions. I think the chat box was blowing up as we were going along. And we are open to any verbal questions that folks have not received answers to in the chat box. Any questions or comments?
Can I make a comment on what CJ just commented on?
Please,
I really like what he had to say about the Yates memo. And I also think, I mean, this is just a theory to me that, and I was reading an article by Robert Waters and Peter Provost, and about no blame and accountability in patient balancing, no blame and accountability in patient safety. And they had mentioned, this was back in 2009, actually, when they wrote this article, but they were talking about how, you know, if balancing the patient, the no blame and the accountability piece, if healthcare doesn't regulate themselves, then somebody else is going to do it for them. And I thought that was back in 2009, and it just resonated with me. And I wondered what CJ had to think about that too.
Yeah, absolutely. Right. So the authority and enforcement agencies have a, and rightfully so in some perspectives, they have a very focused agenda, right? And they almost put blinders on in some cases, and they're like, we're not going to worry about the ramifications. We have to hold this institution accountable. We have to get the ripple effect. It's like throwing a stone in the water and you get the ripple effect. They invest so much enforcement energy and efforts to make an example of the one, because they can't do that in all these other organizations. So sometimes I think that's taken a little bit too far. As has already been mentioned, we don't know all the details. Some people say there's 2 sides to every story. There's probably hundreds of sides to every story. So we don't know all those details, but I think your point is spot on, Amanda.
Yeah.
Just looking at the chat box, there's a couple of questions, I think some of which have already been addressed. I think folks have posted questions even before our session today. The first is, are individuals held accountable at the expense of fixing systemic issues caused by the healthcare industry? cutting corners on staffing, training, equipment, and the health and safety of workers and patients. I think you've got a very biased group of panelists here. We all, as a group and individually, really believe in a balance between individual accountability, but only after resources have been provided, whether that's in the form of time, space, environment, or training. And also once expectations have been standardized across the board. So there is a responsibility that lies at the level of hospital patient safety leaders, operations leaders across the healthcare organization, as well as organization leaders all the way from the top, from the C-suite, all the way down to the front line. There are influencers of practice who are unofficial, unidentified leaders in any organization, and they hold as much power as those with titles. And so my ask to people in healthcare is always, you don't have to have a title to act as a leader. You have influence and power more than you realize. And it speaks to the idea that in this particular case, the way I see it, the nurse actually she actually showed signs of leadership by speaking up. She stepped up. She owned her responsibility. She's shown authenticity and integrity in the process. And it's unfortunate that she didn't get the kind of support that she needed from around her. And it speaks to, again, circling back to the whole piece about culture and climate, both culture within an organization and the climate in which we practice, which is what CJ had spoken about earlier. So to that point, yes, absolutely, there is a responsibility across the board. I think the other question is somewhat related, is that the hospital reported that the patient died of natural causes. And so what are some of the responsibilities of the leaders in transmitting that information correctly? There's also some comments in the chat box around psychological safety. Jonathan, I think, had posted a couple of resources. Jonathan, would you like to speak to some of those? So those who haven't been able to see the chat box will also be able to access those.
Sure. Basically, anything that Amy Edmondson has written, any videos that she's produced, there are tons. You can find them on YouTube. You can find them Institute for Healthcare Improvement. The Fearless Organization is a book that came out just a couple years ago, and it's already made, a bunch of top lists of business books in the past 25 years, and it only came out, like I said, a couple years ago. I have no disclaimer here. I don't make any money off of it, but I can't recommend it highly enough. It's just fantastic because it speaks to it, and there's a lot of references in it. It's actually Amy Edmondson. She's been working on organizational culture for a long time, and then kind of fell into this where she actually, it was a pediatrics unit that she found this on, that when there was a lot of trust and there was a lot of support among staff, they actually reported more errors. They reported more error, but they actually made less. So it turns out that they were talking about these smaller errors, and it was they were fixing them and getting to the heart of them, and it was preventing bigger ones. Like I said, the entire book is great. And I believe that she's working on a new one now, kind of more of a how-to manual. The other book that I would recommend is it's called Patients Come Second. And it talks about what healthcare organizations, their role is. And it's interesting because I brought this up at one of the grand rounds that I gave unintentionally the day after one of the vice presidents at our hospital unveiled his Patients Come First initiative. But it turned out okay, I didn't lose my job. But if healthcare organizations focus on giving healthcare workers what they need, the healthcare workers will put the patients first. When we drive everything about the patient, we miss our opportunities to give the healthcare workers, people who've chosen this career, for a living, not for the money. There are easier ways to make it, but because they care about people, and often all they need is the stuff to do their job the right way. Once you support them, they will in turn elevate the patients and put them first. So that's where administrators need to target their focus.
Thanks a ton, Jonathan. I actually stumbled on that from Patients Come Second, and I enjoyed it so much. There was a time I was giving it to every graduating fellow who was leaving our fellowship program. But I really do think it's one of those books that is really worthwhile for everyone to read. It changes your perspective quite a bit on how patient safety is perceived across the board and how it probably should be perceived across the board. So it's an interesting read. I think there's a couple of other questions. There's particularly one related to error reporting, which we didn't talk about too much earlier. The question is, several organizations, ARC and ISMP included, recommend against using voluntary error reporting as a quantitative measure of patient safety, as it is historically unreliable, and it creates a disincentive for reporting errors. What tools do other organizations use for safety measurement? That's an open question for any of the faculty who would like to take it. Are any of the organizations that use a different type of error reporting?
I guess I can start by saying I don't know of any that don't have some component of voluntary error reporting. And I believe that having a voluntary error reporting system is actually something the Joint Commission requires. That
Could I
said,
just clarify? I'd just like to clarify that question real quick. I was the one that asked it to Zadim Berja. I certainly agree that absolutely that voluntary error reporting is incredibly important. What I'm referring to is the measurement of safety using voluntary error reporting. When reports go up, sometimes there is the assumption that things became less safe, when in fact that's oftentimes the opposite. As reports go up, the safety culture is better. And I just wonder what other organizations are doing in terms of sophisticated ways to measure safety using trigger tools, et cetera, that are beyond error reporting. Sorry to interrupt you.
No, it's fine. Actually, it does get to the second part of the question. Beyond voluntary error reporting, which, like all voluntary reporting, and I'm a medical toxicologist by training too, and rely heavily on voluntary reporting of overdoses to the National Poison Centers, which again grossly underreport things because not every overdose gets reported the same way not every error does. Trigger tools have been one of the more effective ways of developing errors. That was actually something that I did my master's project on. Some of the trigger tools are done to be somewhat contemporaneous, things like the National Early Warning Score, that is tracking vital signs and reporting on them in near real time to try and detect patient deterioration before it reaches a point of the patient having a serious event. The ones I've seen utilized for things like medication safety have generally been retrospective, but they looked at things like antidote administration, like, hey, we're going to pull every instance of naloxone being administered in the hospital and look at that to review all the events when naloxone was administered to determine was there an opioid safety issue as a result. We do the same thing with things like 50% dextrose to look for safety events with insulin, to say, well, how many times do you have to give 50% dextrose in the hospital? And although there's some noise to go with the signal in using things like trigger tools, because some of the uses of stuff isn't a safety issue, it's actually a very appropriate use of it for something other than an adverse event. It can help find events that weren't reported at all. So trigger tools are probably the second best thing besides voluntary error reporting for collecting data. There's other ways that people have looked at it that are probably less good, like M&M reports and closed legal cases and such, but those are generally not very helpful at all in providing timely information.
If I could just add to what Jerry said, there's actually a paper that's free available on. It's a Tale of Two Stories, contrasting views of patient safety, and in it it talks about Charles Billings, who came up with the ASRAS safety reporting system for aviation. Interestingly enough, he's a physician. He said from the very get-go, it was not intended to collect data as far as number of events. Whether you have mandatory reporting, voluntary reporting, it doesn't matter. All reporting is essentially voluntary, and that the reports can shift for a variety of reasons. I remember we were getting a lot of reports in pre-op about a certain instance, and then they disappear, and then they come back, and it turned out that it mirrored when one particular nurse went on vacation. So it had nothing to do with the actual incidents. It just happened to do when she was there, she'd report it. When she wasn't there, it wouldn't get reported. The incidents remained the same. And just like Jerry said, you know, the trigger tools are good, but you do have to do an investigation, especially when you consider something like naloxone. We found our own instance of naloxone being given inappropriately was somewhere between, this was a couple years ago, 30 to 40%, was not an opioid overdose. So if you just look at the raw numbers, that's not going to tell you. You actually have to dig and do investigation with all of this.
I think that you know, that really speaks to the importance of the qualitative aspect of quality and safety. We in healthcare have a very heavy reliance on numbers because if they're concrete, we can relate to them. They're easier to measure than a qualitative approach. But there's so much in the quality and safety field that is qualitative. Even just investigations like Jonathan and Jerry were alluding to are really about the depth of the investigation and not just about, you know, speaking to a couple of people and getting sort of the top edge of the story. And so unfortunately, I always tell people who do quality and safety, especially young folks who are getting into quality and safety, I always tell them, you have to consider it a labor of love. It really is. It's where it starts. If you're going into this because you think that, you know, it's going to be converted into some sort of dollar sign, it's hard to put dollar signs on it. I think there's a growing recognition from peers across the board around it, but that is still at a very, very rudimentary level. You know, the pay for performance model hasn't really worked. We know that. CJ has some comments about value-based reimbursement in the chat box. And how that will be evolving. So we have a lot to look forward to. I think this has been a really interesting conversation. I hope all of you have enjoyed it as much as I have. I always learn from this panel, of this group of panelists. They have a fantastic level of experience together. I think it amounts to probably more than 40, 50 years. Of experience, and it's great to hear from people whose clinical practices are in so many different institutions. It just goes to show how much of our pain is shared, even though it appears that we are all functioning within our own framework. Some of this is common, and that's what we hope to get to in some of our educational programs that we offer through the Department of Medical Education at UIC. Sharon Lanza, our program coordinator, will be sharing some of this information with you. But it really, all of these programs speak to sort of the common frameworks in quality and safety that serve as a foundation, regardless of where you choose to practice. And with that, I'll pass it on to Sharon before we wrap up.
Hi, everyone. I'm Sharon. I'm the program coordinator here at UIC, and I'm really happy to give you more background on our options. Leading the way as one of the nation's first patient safety programs, UIC College of Medicine's Patient Safety Leadership Department offers 2 online CAMI certified graduate options. So a Master of Science in Patient Safety Leadership and a graduate certificate in Essentials in Healthcare Safety and Quality. Our master's degree consists of 9 courses, which is 36 credit hours, and a capstone project where you'll work with mentors on your chosen topic of research. Typically, the master's takes around 20 to 22 months to complete. The certificate is comprised of 3 courses, 12 credit hours, and usually students complete that sequence in around 9 months. Additionally, the program offers standalone professional development courses in Essentials for Clinicians and Digital Health. Our coursework is designed by healthcare professionals and taught by an internationally renowned faculty. UIC's patient safety leadership programs are asynchronous.
Sharon, I think you went on mute. So I think we're having a bit of a...
So if you're interested...
Oh. I think we're having a bit of a technical challenge. So I'm hoping everyone will be able to hear Sharon shortly. But in the meantime, please take a look at the website when you get a moment. It has more details about the program.
Programs. I'm sorry.
Sharon, I think we couldn't hear you for some piece of it.
Oh, no.
Just for the last couple of points, but essentially, I think the important pieces are that we offer a master's, a graduate certificate, and we also offer professional development courses, some of which are CME eligible. Most of these programs will be starting in the fall. We are currently open for applications for the master's as well as the graduate certificate program. And for the professional development courses, they're about 16 weeks long and they are expected to start in the fall. Sharon's posted her contact information in the chat box. Please feel free to reach out to her. She will handhold you in understanding and exploring the programs as much as you need. We also are available on social media. We try to stay up with what's evolving in the quality and safety world, and we post pretty generously on Twitter as well as on LinkedIn. The recording of this program will also be available for all of you, and so we will share that with you directly via your email. Thank you all for joining us. I know it's been over the hour, but it has been a real pleasure. Thanks for sticking around. It's been a lot of fun. I hope all of you have gotten something out of this that you can take back to your home institutions. Feel free to reach out to us with any questions. Even after this event, you can always just respond to Sharon by email and she will forward your questions to us and we'll be happy to connect you with folks who might be experts in the area that you're looking for. Thank you so much, everyone. And a huge thanks to our panelists today. It's a pleasure as always. And to Sharon and Sadhana for all their technical support and coordinating this event today. Thanks so much, everyone. Have a lovely evening.